All right, so this video is going to be 50 high-yield endocrine questions. If this is your first time listening to one of these video series of the 50 high-yield questions, what I do is I go through the NCCPA blueprint for that specific system, so for endocrine, and then I go into each individual NCCPA blueprint topic and pull a few questions from each. So it's a really good way to cram before an endocrine exam or before the Pance if this is an area that you're weak on. And it's, of course, I'll go through some explanations with the questions and some mnemonics along the way. So let's go ahead and get started really quickly. Thank you so much for all the comments. The thumbs up, the new subscriptions, and if you haven't subscribed yet, if I could ask one favor, if you wouldn't mind subscribing to the channel, it really helps get the word out about the channel, and it really helps me get more people to be able to see the page in the search results. So thank you so much for that. Let's go ahead and get started with 50 high yield endocrine questions. So question 1, patient presents to the office with polyuria and polydipsia. He has a family history of diabetes and he wants to be tested to see if he is diabetic. He last stayed 2 hours ago and his blood glucose in the office was 156. His A1C comes back and reveals a result of 6.3, and his 2-hour glucose tolerance test revealed a blood glucose of 212. Which one of these lab tests can definitively make the diagnosis of diabetes in this patient? So in this patient, that would be the 2-hour glucose tolerance test with a blood glucose of 212. So his blood sugar in the office was 156, but that doesn't help us because it's not fasting, because he ate 2 hours prior, so it's not a fasting blood glucose, so we can't go by that 126 or higher to diagnose. Then his A1C, it's elevated, but it's not high enough to diagnose diabetes. It needs to be 6.5 or higher. He was only 6.3. Then finally, we have the 2-hour glucose tolerance test, which is positive if after giving 75 grams of glucose 2 hours later, the blood sugar is 200 or higher. This patient was 212, so we make the diagnosis. The only one I didn't mention as far as diagnosis would be the random plasma glucose of 200 or higher in the presence of classic diabetes symptoms or complications. So in this patient, it will be the 2-hour glucose tolerance test with a blood glucose of 212. Question 2, a 66-year-old male presents to the office today because his diabetes is out of control lately and he would like to get some help getting his blood sugars back to normal. He only currently takes metformin 1000 milligrams BID. We discuss a few different medications with him, including glipizide, insulin glargine, and empagliflozin. He states his only fear with starting a new medication is low blood sugars. Which one of the medications discussed with the patient is least likely to cause hypoglycemia? So the only one the only one that listed here would be empagliflozin. So the other two, glargine is a basal insulin, and as we know, all types of insulin have the potential to cause hypoglycemia. And then we have glipizide, which is a sulfonylurea. It's an insulin secretagogue, so basically it makes the pancreas secrete insulin, and it's notorious for causing low blood sugars. All the ones in the sulfonylurea class, so glipizide, glimepiride, glyburide, they can all cause low blood sugars. So the only option is empagliflozin, which is Jardiance, and it's an SGLT2 inhibitor, does not usually cause low blood sugar, so that would be the best option for this patient who has a fear of low blood sugars. Question 3, what is the most common type of thyroid cancer? Most common type of thyroid cancer would be papillary thyroid carcinoma. About 8 out of 10 cases is papillary thyroid carcinoma. Question 4, a non-pregnant adult with subclinical hypothyroidism should be treated with thyroid hormone replacement like levothyroxine when their TSH reaches what level? So that level is going to be 10 or above. So treatments in patients below that from like 4.5 to 10, it's controversial. Guidelines are going to say, one will say yes, one will say no, but virtually all sources agree upon treating once the patient's TSH is 10 or higher, and that's how they're going to ask you on an exam, because they can't ask you something that the guidelines are all different. So 10 or higher, definitely you treat, you prevent cardiovascular complications at that level. Question 5, a 27-year-old female with history of bipolar disorder presents to the office complaining of fatigue, constipation, and weight gain. Labs are ordered and it is determined she is biochemically hypothyroid. What medication is this patient likely taking that led to her diagnosis of hypothyroidism? So the medication she's likely taking would be lithium. So in the vignette, we saw that she has a history of bipolar, and we know a first-line med for bipolar is lithium. You just have to know that lithium can absolutely cause hypothyroidism. It's just one of those questions they love to ask. And actually, when you're on lithium, you actually need to have your TSH checked every 6 to 12 months because it's so prevalent, hypothyroidism. The other one that they may ask you about is amiodarone. That's another popular one that can cause hypothyroidism. That's like a kind of like a board favorite. So amiodarone and lithium, you have to know those can definitely cause hypothyroidism, and you need to know that for the exam. Question 6, 36-year-old female presents to the office complaining that she is having trouble losing weight despite following a strict diet and exercising daily. On physical exam, you note central obesity, thin extremities, oily skin, and striae across her abdomen. Screening test to check for excess of what hormone should be checked in this patient. So the hormone that we would be checking for in excess would be serum cortisol. This patient has pretty classic findings of Cushing's syndrome. So weight gain, striae, which are stretch marks on the abdomen, oily skin, thin extremities, central obesity. The only thing I didn't mention in the vignette, because I try to make it not so obvious, is the buffalo hump, but that's another one you'll see in Cushing's. And then in Cushing's, we know we look for increased cortisol levels. Once we establish the increase in cortisol, then we can use the differentiating test to see if it's Cushing disease or an ectopic ACTH producing source. Question 7, patient with secondary hypothyroidism will have an abnormality in which part of the hypothalamic pituitary thyroid axis. So which part of that axis is giving us problems in secondary hypothyroidism? That would be the pituitary gland. So secondary hypothyroidism is caused by TSH deficiency, and we know that the pituitary gland is responsible for TSH production. So anything like a pituitary tumor, Cushing's syndrome, which is postpartum pituitary necrosis, can all be responsible for secondary hypothyroid disorder from the pituitary. Question 8, what is the most common cause overall for Cushing's syndrome? So most common cause overall would be long-term high-dose use of glucocorticoids. Question 9, in a patient with diabetic ketoacidosis, after checking capillary glucose levels, checking urinary ketones to confirm the diagnosis, what is the first therapeutic intervention that should be started in these patients? So the first thing you got to start in a patient with DKA would be starting IV fluids. So first step, infusion of isotonic saline. These patients are severely dehydrated. After that, you can go ahead, or at the same time, start repleting your potassium if you need to, give insulin. But right away, these patients need IV fluids, and again, it's normally with isotonic saline. Question 10, 69-year-old male with type 2 diabetes for over 25 years presents to the office today complaining of early satiety, epigastric discomfort, and postprandial nausea and bloating for many months. What is the likely diagnosis in this patient? So this one's a pretty clear cut. You'll probably see this question. That's going to be diabetic gastroparesis. So diabetes mellitus is the most frequently recognized disease associated with gastroparesis. What gastroparesis is, if you're not familiar, it's a delayed gastric emptying from years of damage from diabetes, which can lead to the diabetic autonomic neuropathy. It affects the vagal nerve, and it leads to basically reduced frequency of the contractions of the stomach, the antral contractions, which can lead to this delayed gastric emptying, as well as some other manifestations. So definitely gastroparesis is a big one in diabetic patients, especially long-standing diabetes who are poorly controlled. Question 11, patient with nephrogenic diabetes insipidus will likely have what response in urine output after a desmopressin, which is artificial ADH, stimulation test being performed? So nephrogenic diabetes insipidus, you give desmopressin, what is going to happen? Nothing, no change, continued production of large amounts of dilute urine. So the reason is in nephrogenic causes, there's plenty of ADH floating around. It's not a lack of ADH. It's just the kidneys are ignoring the ADH. They're insensitive to ADH. This is compared to central, which is a lack of ADH production. So in central, you give them desmopressin again, which is artificial ADH, and all of a sudden they start improving because it's a lack of. But nephrogenic, again, there's no problem with the ADH production. There's plenty floating around. The kidneys are just choosing to ignore it. So the way that I used to remember diabetes insipidus was I would say diabetes insipidus, DIA. Central is decrease in ADH. Remember, decreased production of ADH by pituitary. And then nephrogenic was decrease in acknowledgement because the kidneys are just not acknowledging or responding to the ADH. Question 12, what medication class, if given to a patient with Pheochromocytoma, before initiating treatment with alpha adrenergic blockers like phenoxybenzamine, can cause unopposed alpha constriction and lead to a hypertensive crisis? So what med, if you give before alpha blockers, can cause a hypertensive crisis? It's going to be your beta blockers. So after you've initiated treatment with alpha blockers and you achieve adequate alpha adrenergic blockade, then you can start beta blockers like propranolol, metoprolol. But this is normally done preoperatively. But if you start beta blockers first, you can cause this hypertensive crisis, which is caused by the unopposed alpha constriction. So never give beta blockers before alpha blockers in a patient with pheochromocytoma. 13 was the most common cause of hypothyroidism in the U.S. Pretty straightforward one. You should know this one, Hashimoto thyroiditis, chronic autoimmune hypothyroidism, and most common cause of primary hypothyroidism in the U.S., as well as what they called iodine sufficient areas of the world. So places like the U.S., we have iron supplementation in our salt and other things, so iron's not a problem here. So for us, it's going to be an autoimmune cause rather than iodine deficiency. Question 14, in a patient with history of Graves' disease, presenting to the office with bilateral, scaly, non-pitting induration of the skin of the lower extremities with brown patches spread throughout. What is the name of the likely diagnosis that this patient has? So this is something known as pre-tibial myxedema. It's an autoimmune reaction that can be seen in patients with Graves' disease, and it's caused from an accumulation of excess, they're called glycosaminoglycans, in the dermis of the skin, and it can cause these swollen red-brown patches. What's very key here in the vignette is that it's non-pitting edema, because this helps differentiate from other causes like CHF, which can cause pitting edema in the lower extremities, but this is non-pitting. Most common in the pre-tibial area, the lower extremities, but it can also be seen in the foot, elbows, knees, etc. And that's what it looks like on exam. Question 15, when treating a patient with Graves' disease, which medication should be used in the first trimester? So first trimester, you're going to use PTU, propylthyracil. You use PTU during the first trimester, and it's really the only time when PTU is preferred over methimazole. And then after that, you can switch over to methimazole for the rest of the pregnancy. But PTU first trimester, there's some guidelines that are starting to say maybe you could use PTU the whole time, but definitely first trimester. And as far as the guidelines have said up until now, methimazole for the rest of the time. And the way I used to remember that was PTU, propylthyracil, stands for pregnancy trimester uno. Remember, it's used during the first trimester of pregnancy, patients with Graves' disease. Question 16, patient develops bladder cancer and it is suspected that one of the medications he uses for diabetes is to blame. Which diabetes medication is this patient likely taking? So the diabetes medication he's likely taking is pioglitazone. This drug carries an increased risk for bladder cancer. It's in the TZD class along with rosiglitazone. The way that I used to remember this was pioglitazone instead of pioglitazone. I used to remember pioglitazone. P obviously makes you think of the bladder. You see this guy peeing here next to the bladder. So TZD class diabetes medication has an increased risk for bladder cancer. You won't forget that pioglitazone. Question 17, a patient with Cushing's disease, which is a pituitary cause, after administration of high-dose dexamethasone will likely have what response in their serum cortisol levels? So patients with Cushing's disease after high-dose dexamethasone is going to have a suppression of serum cortisol. So Cushing's disease, pituitary source again, it's the only one that's going to suppress with high-dose dexamethasone. So that's really important to differentiate on an exam question. Other ectopic sources of Cushing syndrome, like adrenal tumors, ectopic ACTH tumor, exogenous steroids, they're not going to suppress in cortisol levels with high-dose dexamethasone. So just so you know, this test in practice has variable sensitivity and specificity. It's the one they always seem to ask you about on the exams, but in real life, we normally combine either a desmopressin test or a CRH with the dexamethasone test. But for the exams, this is all you need to know. Question 18, sorry, I do work in endocrine, so I might throw a few things just from clinical experience in there along the way. I apologize for that. I know you'd rather probably just focus on the exam, but 47-year-old female presents to the office 2 weeks post-op after having a thyroidectomy performed. She complains of muscle cramping and muscle spasms as well as a tingling sensation in her extremities. An ECG is performed and prolongation of the QT interval is visualized. What is the likely cause of her symptoms? So this one, pretty characteristic findings for hypocalcemia. So this is going to be an iatrogenic cause of hypoparathyroidism leading to the hypocalcemia. So we see in the history she had a thyroidectomy performed, and hypoparathyroidism actually occurs in about 3% of patients after a total thyroidectomy. So during the surgery, a number of things could have happened. They may have inadvertently removed some of the parathyroid glands. There could have been like a mechanical or thermal injury from the cauterization to the glands. Whatever the cause is, you've destroyed or removed some of the glands, which leads to this hypoparathyroidism with resultant hypocalcemia. And this patient has classic presentation, paresthesias, muscle weakness, and then most importantly, that prolongation of the QT interval on ECG. Question 19, a 37-year-old female presents to the office today because she has not had her period in 4 months. She's not sexually active and denies any chance of pregnancy. She also complains of headaches and a milky discharge from her breast. What is the first-line medication class for the likely diagnosis in this patient? So that's going to be your dopamine agonist, so cabergoline, bromocriptine. Patient in this vignette with amenorrhea, galactorrhea, headaches, which is caused by the compression from the adenoma, likely has a prolactinoma. It's the most common type of pituitary adenoma. So why do we use dopamine agonists? Well, the primary function of dopamine is to inhibit prolactin. So dopamine agonists mimic the action of dopamine, and they're going to decrease prolactin secretion and synthesis. And generally, we use cabergoline rather than bromocriptine as a more favorable side effect profile compared to bromocriptine. Question 20, multiple endocrine neoplasia type 1 is a rare autosomal dominant disorder characterized by a predisposition to tumors, most commonly in what 3 areas of the body? So that's going to be your 3 Ps. So it's parathyroid, pancreas, and pituitary are the most common areas that the multiple endocrine neoplasia type 1 can be found in. Question 21, a 56-year-old male with a history of diabetes presents to the office today to review recent lab results. His labs show that he's deficient in vitamin B12. Which medication is he likely taking for his diabetes that caused a deficiency in vitamin B12? So the medication he's most likely taking would be metformin. Metformin can reduce intestinal absorption of vitamin B12, and it can cause vitamin B12 deficiency in around 5 to 10% of patients taking the med. Question 22, what is the most aggressive type of thyroid cancer? So this is by far anaplastic thyroid carcinoma. It's extremely aggressive, which is different than most of the other types of thyroid cancer. And the median survival time from diagnosis is unfortunately about 3 to 7 months. Question 23, how soon after the initiation of thyroid hormone replacement, levothyroxine, whatever you're using, in a patient with primary hypothyroidism should the TSH be checked? So you just started levothyroxine. When are we going to check the TSH? That would be 4 to 6 weeks after the initiation of levothyroxine or whatever thyroid hormone you're using, Armour thyroid, etc. 24, 42-year-old male presents to the office for routine labs. The results of the lab show an elevated TSH level and free T4 levels which are within normal limits. Patient is otherwise healthy and asymptomatic. What diagnosis should be suspected in this patient? So we just have an isolated elevated TSH, but your T4 levels are normal. What we should be suspecting is subclinical hypothyroidism. So isolated increased TSH, normal serum free T4, in the absence of clinical manifestations of hypothyroidism. Right away should be thinking subclinical hypothyroidism. It's possible sometimes these patients will have like these mild, vague, nonspecific symptoms, but generally they're going to be asymptomatic with just an elevated TSH. Question 25, physical exam is performed on a newborn female due to abnormalities detected at birth. Newborn has dry skin, swelling around the eyes, enlargement of the tongue, and an umbilical hernia palpated on exam. What nutritional deficiencies should be suspected in the mother of the newborn? So this would be an iodine deficiency. So this newborn has classic symptoms of untreated congenital hypothyroidism. It's also known as cretinism. So macroglossia, which is the enlarged tongue, umbilical hernia, facial edema, dry skin, all classic findings. Most common causes in developing countries is going to be lack of maternal iodine intake. Here in the US, it's uncommon because, like I mentioned before, one, because of screening programs, and then two, we have iodine added to, plenty of things like salt, plenty of other foods. So we don't generally have iodine deficiency here. In the US, if we do see a newborn with this, it's generally from an embryologic defect in the thyroid gland development or a defect in the thyroid hormone synthesis rather than maternal iodine deficiency. Question 26, 37-year-old female presents to the office today complaining of persistent fatigue combined with nausea, generalized abdominal pain, and a brownish discoloration on her hands, elbows, and knees. Labs are ordered and reveal elevated serum potassium levels and a blood glucose of 63. What is the likely diagnosis in this patient? So likely diagnosis would be primary adrenocortical insufficiency, also known as Addison's disease. So this patient has fatigue, nonspecific GI complaints, hyperpigmentation of her skin, and then of course hyperkalemia and hypoglycemia found in labs. They're all commonly seen in this disorder in primary. But the question, not so much the fact that she has adrenocortical insufficiency, but is it primary or secondary? Obviously I said it was primary, but the reasons why it's primary is because of the presence of hyperpigmentation of the skin and hyperkalemia, which are generally only seen in primary but not in secondary. So that's what would lead you to primary rather than secondary adrenocortical insufficiency. What would the ACTH levels in the previously discussed patient, would they be elevated or decreased? So the patient we just mentioned that had Addison disease, where are the ACTH levels going to be? Are they going to be elevated or are they going to be decreased? So in this patient, they're going to be elevated. So primary adrenocortical insufficiency or Addison's disease is due to adrenal gland destruction, meaning the adrenal is not producing enough cortisol, also aldosterone, but what's important here is the cortisol. And this leads to increased ACTH from the pituitary. It's trying to raise those cortisol levels. It's failing, obviously, but that's what it's trying to do, and that's why the ACTH is high. Whereas in secondary, you have decreased ACTH because it's pituitary failure, which leads to decreased ACTH secretion. And just a follow-up to the previous question, the increased ACTH in primary is what causes the hyperpigmentation of the skin, which we saw, and then the decrease in aldosterone is what leads to those electrolyte abnormalities like hyperkalemia, as well as hyponatremia, which wasn't mentioned in that vignette, but it is something else we see in primary. Question 28, 36-year-old female presents to the office complaining of fatigue, constantly feeling cold, dry skin, and weight gain. If thyroid hormone levels were drawn in this patient, what would the levels of TSH and free T4 likely reveal? So in this patient, we would likely see an elevated TSH and decreased free T4. So these are classic symptoms of hypothyroidism: fatigue, weight gain, cold intolerance, dry skin. And in hypothyroidism, we know the classic lab findings are going to be an elevated TSH and a decreased free T4. Question 29, patient with hypothyroidism comes in for routine follow-up and to review labs she had done to evaluate her thyroid hormone levels. She takes 50 micrograms of levothyroxine daily and has been on this dose for the last 9 years with no issues. Labs come back indicating she is biochemically hypothyroid and her TSH is 11. She states she has not made any changes since the last visit and assures you that she always takes her levothyroxine first thing in the morning and waits an hour before eating or taking any other pills. She's not started any new prescription medications, just an over-the-counter med she started a few weeks ago for some heartburn she's been experiencing. What is the likely cause of this patient's sudden increase in TSH? So what the cause is actually the OTC heartburn medication. So it's likely a PPI or an acid that she's taking. Doesn't matter. Whatever the heartburn med she's taking is causing problem with the levothyroxine absorption. So levothyroxine actually requires an acidic environment in the stomach to be effectively absorbed. And as we know, PPIs or an acids reduce or neutralize that acid in the stomach, which can lead to decreased absorption of the medication. So while we suggest waiting an hour before taking other pills, PPIs, as well as some antacids, vitamins, calcium supplements is another one, actually need about a 4-hour buffer period. So no levothyroxine 4 hours before or after taking these meds, like in this patient, the PPI or an acid, because we can see a decrease in the efficacy, which leads to the increased TSH we see in this patient. So most meds are 1 hour, but remember there's certain ones like calcium, your PPIs, that need a 4-hour buffer period. Question 30, 47-year-old female has recently started methimazole for treatment of Graves' disease. She often feels very jittery, anxious, and sometimes feels as if her heart is beating out of her chest. In addition to methimazole, what medication class can be used in this patient to rapidly improve her symptoms? So the med we would use for symptomatic control would be beta blockers. So propranolol, atenolol. Beta blockers alleviate the symptoms of hyperthyroidism that are caused by the increased beta adrenergic tone. So symptoms like palpitations, like tachycardia, anxiety, they can all potentially be eliminated or at least improved pretty rapidly with beta blockers. Question 31, what would be the first-line medication to use in a patient with acromegaly due to a pituitary adenoma? So first-line medication would be a somatostatin analog. Octreotide is the one you'll most commonly see on the exam question. Lanreotide is another one. So basically, it's very simple. The somatostatin inhibits the release of growth hormone. So that's why you give these medications in these patients. Question 32, a 42-year-old male presents to the office complaining of decreased libido, erectile dysfunction. He has a history of type 2 diabetes, hypertension, hyperlipidemia, and bipolar disorder. His medications include Zocor, amlodipine, metformin, and risperidone. Labs are drawn which reveal an elevated prolactin level. What would be the first-line treatment option for this patient? So the first-line treatment option for this patient is going to be to discontinue the offending agent, which would be risperidone. So this patient has hyperprolactinemia. The cause is the risperidone he's taking. So risperidone, as well as other dopamine antagonists like haloperidol, can lead to hyperprolactinemia. And the reason is because these agents are dopamine antagonists, so they block the effect of dopamine. And what does dopamine do? It's an inhibitor of prolactin. So decreased dopamine, more prolactin, which leads to hyperprolactinemia like we see in this patient. So first line treatment, stop the risperidone and find another agent for his bipolar disorder. Question 33, what medication can be used in a patient with primary hyperparathyroidism to lower serum calcium and serum PTH that is not a candidate for surgery? So the medication we would use is something known as cinacalcet. This is a calcium mimetic, and it works by lowering the parathyroid hormone levels by increasing the sensitivity of the calcium sensing receptor. So it kind of tricks the body into thinking there's more calcium floating around than there actually is. So it doesn't produce as much PTH. You have less PTH, you have less calcium released. And remember, another option too is if the patient has osteoporosis, we can use bisphosphonates as well. But cinacalcet's the one you'll normally see. Question 34, patient with history of type 1 diabetes presents with tachycardia, weakness, altered mental status, and a fruity, also known as an acetone breath. Finger stick is done bedside, which reveals a blood glucose of 560, and his urine is positive for ketones. On physical exam, you note deep, rapid, and labored breathing. These respirations are a compensatory mechanism for what acid-base disorder that is likely present in this patient. So the patient obviously has DKA. What is the acid-base disorder that he has? That's going to be a high anion gap metabolic acidosis. So remember, DKA, I'll show you right here, is the D in mud pilers. This is just something that you have to know because they might ask you a question. So mud pilers is some of the main causes of anion gap metabolic acidosis. DKA is a big one. So what this patient is doing, it's known as Kussmaul respirations. It's a compensatory mechanism for the metabolic acidosis this patient's experiencing. It's the body's way of trying to increase the rate and depth of respiration to blow off some excess CO2. Question 35, patient presents to the ER after sustaining a head injury in a motor vehicle accident. Since the accident, he has been urinating more frequently than normal, and he has developed an insatiable thirst. His urine is dilute, and a finger stick blood glucose reading is 98. What is the first-line treatment for the likely diagnosis in this patient? So this patient, we're going to give desmopressin. So he has polyuria, polydipsia, sudden acute presentation. You should definitely be suspecting diabetes insipidus. They tell you the urine's dilute, and then they tell you the blood glucose is normal, so diabetes mellitus is kind of out of the question, even though it should be out of the question anyways because of the rapid onset. But the normal finger stick seals the deal. So now we just have to decide whether this is central or nephrogenic. So they don't give you the results of a desmopressin stimulation test. We just have to go by the history. And the fact that this patient presents with symptoms after a head injury, which is one of the causes of central diabetes insipidus, with no mention of medications or electrolyte abnormalities, we have to for us to suspect nephrogenic. So we know that likely this is going to be a central diabetes insipidus, and the first line treatment for central is going to be desmopressin. Question 36. 46-year-old male is diagnosed with SIADH. He has a history of seizures, asthma, hypothyroidism, and hyperlipidemia, and is taking atorvastatin, levothyroxine, an albuterol inhaler, Lovaza, and carbamazepine. Discontinuation of which medication is recommended in this patient because of the history of SIADH, and that is going to be carbamazepine. So almost all anticonvulsants have the potential to cause SIADH, but carbamazepine in particular, it's the one they always seem to like to ask about. Other medications, hydrochlorothiazide, SSRIs, IV cyclophosphamide, can all predispose a patient to SIADH, but don't forget carbamazepine. That's kind of like one of those favorite ones they like to ask about. Question 37, what screening test should be done annually for diabetic patients to screen for early signs of diabetic nephropathy? So the test you're going to do for that is known as your urinary albumin. It's also another one is a spot urinary albumin to creatinine ratio. So albumin is a protein that's in the urine. It's normally too large to get through a healthy functioning kidney, or it's in the blood. Normally too large to get through a healthy functioning kidney. But once the kidney becomes damaged, it's no longer able to retain that albumin back into the body. We start to see it spill out into the urine. It's an early sign of diabetic nephropathy. Anything above 30 used to be called microalbuminuria, not anymore, and now it's called moderately increased. So anything from 30 to 300 is moderately increased albinuria, and then anything over 300 is called severely increased albuminuria. Question 38, what is the most common cause of diabetic ketoacidosis? So most common cause of DKA is going to be infection, like pneumonia, UTI. Most common precipitating factor is infection. It's because you get these counter-regulatory hormones that are released, like epinephrine, and these hormones that are released in response to the infection actually lead to insulin resistance, volume depletion, ketogenesis, all of the main ingredients for DKA. Question 39, a patient with hypocalcemia has contraction of facial muscles provoked by light tapping on the facial nerve just anterior to the ear. This is known as the Vostek sign. So Vostek sign you can see in hypocalcemia, twitching in that facial nerve of the face and like the cheek area. Question 40, a 64-year-old female with history of type 2 diabetes presents to the office due to her blood glucose running higher for the past few months. She's made dietary changes as well as increasing her activity level with no improvements in her readings. She agrees to add another medication to her regimen, and you discuss a few medications with her, including epagliflozin, liraglutide, and glipizide. She states her only requirement is that the medication will not cause her to gain weight. Which of these three medications discussed should be avoided if you don't want her to gain weight? And that medication is going to be glipizide. So glipizide is a sulfonylurea, and it can cause weight gain. The other two listed, liraglutide, which is a GLP-1 receptor agonist, which can cause weight loss, actually, the opposite. And then epagliflozin, which is an SGLT2 inhibitor, can also cause weight loss. So the way that I used to remember the ones that make you gain weight, because there's really only three, is that if you sit too much, you can get fat. So if you sit too much, you can get fat. SIT stands for sulfonylureas like glipizide, glimepiride, insulin, any one of the insulins, and then TZDs, which is that rosiglitazone. Those ones can all make you gain weight. Anything else, any of the other diabetes medication classes are either weight neutral, like metformin's generally weight neutral, or the other ones can cause weight loss, like the epagliflozin, liraglutide, and those ones. But the three that you need to know for weight gain are sulfonylureas, insulin, and TZDs. Question 41, what diagnosis should be ruled out in a patient who has a radioactive iodine uptake scan of the thyroid performed that shows little to no iodine uptake, which is also known as a cold nodule? So what you need to rule out here would be malignancy. So these patients need further testing to rule out malignancy. With it, normally we do a fine needle aspiration. It's still really rare, even in a cold nodule, to see a thyroid malignancy, only about 5%. Question 42, a 46-year-old male with a history of inflammatory bowel disease, hyperlipidemia, pancreatitis, renal failure, and trigeminal neuralgia is going to be started on metformin for his newly diagnosed type 2 diabetes. Which medical condition listed in his history would be a contraindication to starting metformin? So the history that he has, which would be a contraindication, is going to be renal failure. So due to the increased risk of lactic acidosis with metformin, patients with renal failure shouldn't be started on this med. GFR cutoff is generally less than 30, that this medication is absolutely contraindicated. Question 43, what is the most common cause of hyperthyroidism? Most common cause of hyperthyroidism is going to be Graves' disease. Question 44, a 46-year-old female presents to the emergency department because she feels like her heart is beating out of her chest and is also complaining of a persistent headache. On exam, she is diaphoretic, has a pulse of 122, and blood pressure of 162/108. Her labs show that her plasma fractionated metanephrines are significantly elevated. CT of her head, abdomen, and pelvis are performed and discover a mass. For the likely diagnosis in this patient, where would this mass most commonly be located? So that would be the adrenals. This patient has a pheochromocytoma, which is evident by the classic triad of headache, sweating, tachycardia, as well as her being hypertensive, which is another key finding. And then, of course, the elevated metanephrines, which is key there. So since a pheochromocytoma is a catecholamine-secreting adrenal tumor, the mass obviously is going to be found on imaging in the adrenals. And just an FYI, it's possible to have an extra adrenal catecholamine-secreting tumor in a pheochromocytoma. It's called paraganglioma. It's not common. You're not going to be tested on it, but just so you know, generally you're going to see it in the adrenals in a pheochromocytoma. Question 45, a 67-year-old male with history of type 2 diabetes presents to the office today complaining of shortness of breath that is increasingly getting worse. He also noticed an unexplained weight as well as swelling in his lower legs. On physical exam, pitting edema is noted in the lower extremities, and rails are auscultated at the lung bases. He was started on a new oral diabetes medication a few months ago by his endocrinologist, but he cannot remember the name. Which class of diabetes medication was he likely started on that has led to his current presentation? So the class that he has started on is known as your thiazolidinediones. That's why we call this the TZD class. So that includes rosiglitazone, pioglitazone. These meds actually carry a black box warning for CHF. They can either cause or exacerbate congestive heart failure. That's why these meds are rarely used. There's a lot of problems with them. They're cheap, but that's really about the only positive with these. So TZDs can cause or exacerbate CHF, which we see in this patient. Question 46, a 45-year-old male presents to the office complaining that his wedding band no longer seems to fit and some of his hats seem to be too small. He also complains of headaches as well as some visual changes. What would the initial test of choice be for this patient to screen for the likely diagnosis? So that's going to be your insulin-like growth factor, also known as your serum IGF-1. So this patient has a clear presentation for acromegaly, which is caused by a growth hormone secreting pituitary adenoma, also known as a somatotroph adenoma. So we measure the serum IGF-1 concentrations because they're elevated in virtually all patients with acromegaly, and they provide excellent discrimination from normal individuals. Just remember that the name of this disease is all based upon whether or not the epiphyseal plate in the bone is closed yet. So in adults, it's closed. That's why we call it acromegaly. In children, not yet closed. It's called gigantism. Same thing, just all depends on whether or not that's closed. The way that I used to remember that is acromegaly starts with an A, so that just helps me remember that it's seen in adults. Adults, acromegaly, both start with an A. Question 47, 72-year-old female presents to the office today for routine checkup. She forgot to bring her medication list, but says she was started on a new medication for diabetes. She says all that she can remember about the medication is that it's supposed to flush the glucose out through the urine. Which class of medication is this patient likely taking? So she is likely taking an SGLT2 inhibitor like empagliflozin, canagliflozin. They all end in gliflozin. The way that I used to remember, that's not the greatest mnemonic, but I used to remember that SGLT2 inhibitors all end in gliflozin, and then I break down the letters of gliflozin. GL stands for glucose, I stands for is, and then flozin. Glucose is flozin out of the body. It's not a great one, but it's kind of stuck in my head over the years. Question 48, what is the most common cause of primary hyperparathyroidism? Most common cause is going to be a parathyroid adenoma. Question 49, an 86-year-old female is brought to the ER today by rescue. She was found in her apartment unconscious by a neighbor who called 911. On exam, her pulse is 46, her blood pressure is 82/52, and lab findings reveal her free T4 levels are so low they are undetectable. Family member who accompanies the patient today states she normally has a nurse who comes to the house every day to dispense her medications, but unbeknownst to the family, she's not shown up for over 3 weeks. What medication was this patient likely taking daily prior to her nurse not showing up? This patient was likely taking levothyroxine, also known as a brand name Synthroid, or any other thyroid hormone replacement. So this patient has what's known as a Myxedema Coma. It's an extreme form of hypothyroidism that's evident in this patient due to the bradycardia, hypotension, extremely low free T4 levels, and these patients can also have hypothermia, hypoglycemia, and generally we see this in elderly patients. It can be in non-compliant patients with their thyroid hormone like we saw in this vignette, but more commonly it's from some acute precipitating event like an MI or infection. Last question 50, 36-year-old female presents to the office complaining of fatigue, polyuria, and recurrent candidal infections. Screening for what condition should be performed in this patient? So that would be diabetes mellitus. So fatigue, polyuria, all common in patients with diabetes, but the key is the recurrent candidal infections. So they're really common in diabetic patients due to the increased glucose in the urine. So glucose promotes adhesion of candida to either the vaginal epithelium or even the buccal mucosa, which can lead to impaired phagocytosis, and it can lead to these recurrent either vulvovaginal candidiasis or even thrush when it sticks to the buccal mucosa. All right, good thing it was the last question because I'm losing my voice. So that was it. I really hope that was helpful. Please let me know in the comments if these videos are helping you basically. And please, if you haven't subscribed yet, please do. I would really appreciate that. Thank you so much. And good luck in PA school. Good luck on your PANCE, your Panre, your EOR. And thank you so much for watching the video.